A warm welcome to IHRS 2020. I'm Dr. Deep Chand. I'm a clinical cardiac electrophysiologist from the Australian National University, and I work at the Canberra Hospital. I'm going to talk on principles of commonly used EP maneuvers in differentiating atrial tachycardias, AVRTs, and atypical AVNRTs. Even before getting to the pacing maneuvers during the tachycardia, it is very important to derive diagnostic clues by observing the VA relationships, VA timing, and the atrial activation sequences. The mode of induction and termination of the tachycardia are also very important, and the cycle length variations and the influence of these on the tachycardia also give important diagnostic clues. Let us take this for an example, a long RP tachycardia with 1:1 A to B relationship. A simple maneuver, like delivering a premature atrial complex, has resulted in a VA, the return cycle VA, which is much longer than the VA during the tachycardia, thus exposing a variable VA linking, which can happen only in atrial tachycardias. Let me restrict my talk to the principles behind ventricular pacing. Let us start with a schematic model. In an atrial tachycardia, when the foci is within the atrium, it fires from the atrium, gets into the AV node, gets down in the ventricle. For example, if this goes on in a 1:1 fashion, and when you start ventricular overdrive pacing, there are two types of responses that you can observe. The first response, it might block within the AV node, leading to dissociation of the ventricle from the tachycardia. The second response, the ventricular impulse might get into the atrium past the AV node and suppress the atrial foci, what we call the overdrive suppression. So during ventricular pacing, you will observe a VA, VA, VA going on. What happens when you stop ventricular pacing? The last atrial impulse does not get into the AV node because it would find the AV node in a depolarized state, refractory. And when the atrial tachycardia resumes, it would resume with an atrial EGM, and hence you would observe a VAAV response, very specific for an atrial tachycardia. An orthodromic AVRT is a macro reentry circuit involving the atrium and the ventricles, whose activation occurs in series, one following the other. When you ventricular overdrive pace, the impulse can travel in two directions. It can either travel through the accessory pathway to get into the atrium or through the His-Purkinje system. If it gets into the His-Purkinje system, it would collide with the orthodromic wavefront of the tachycardia, resulting in termination of the tachycardia. If it gets past the accessory pathway into the atrium, then it would advance the atrium to its own cycle length. That might be evidence of fusion on the surface ECG. This fused QRS complexes are because of the collision of the wavefronts from the pace stimuli, and that during the tachycardia. With continuation of ventricular pacing, the whole circuit is now reset to the paced cycle length. What happens when you stop pacing? The ventricular impulse still manages to get into the atrium through the pathway and gets down through the His system back to the ventricle. Hence, you would observe a VAHV response post cessation of pacing. In contrast, atypical AVNRT is a very small circuit which revolves in and around the AV node. It does not require the atrium or the ventricle for sustenance of the circuit, and the atrium and the ventricle are activated in parallel. when you ventricular overdrive pace an AV and RT circuit, you might still observe fused complexes on the surface ECG. You can dissociate the ventricle from the tachycardia circuit and the tachycardia can still continue. But in no way the ventricular impulse can get into the atrium without bypassing the circuit. With continuation of ventricular pacing, you might succeed in entering the circuit, fuse with it within the AV node, and then start entraining the atrium to the paced cycle length. So when you stop pacing, the atrial impulse would return back through the lower common pathway, through the His system and then to the ventricle, and then one part of it would travel back to the atrium. Hence, after stopping of ventricular pacing, you will see a VAHB response just like in AVRT, except that His and the atrium in AV-NRT is activated in parallel. Let's move on to the post-pacing intervals. As you see on the left side of the screen, the AV-RT circuit, because you're pacing from and within the circuit, the post-pacing interval approximates the tachycardia cycle length. But in an AV-NRT, because the circuit is so small and you're pacing away from the circuit, it takes longer time for the impulse to go and come back to the recording electrode. Hence, the PPI is going to be very long. Certain cutoffs have been laid, 110 and 85 milliseconds. 85 milliseconds for the differences in STIM2A to the V2A. Any interval less than these cutoffs would go in favor of AV-RT, and more than these would favor an AV-NRT. But an important caveat of post-pacing interval one has to remember is the distance from the circuit. For example, as shown here, an orthodromic AV-RT involving a left-sided pathway, and if you are pacing from the right ventricle, it's going to take a really long time for the impulse to get back to the recording electrode. So you will have a long post-pacing interval from the right side of the heart. The same holds true even for an AV-NRT circuit. If you pace from point B, much nearer the annulus, it's going to take a longer time for the impulse to go past and come back to point B than to point A. And hence your post-pacing intervals are going to be very long. Let us move on to some traces. Here is a ventricular overdrive pacing at 270 milliseconds, 20 milliseconds shorter than the tachycardia cycle length. First question, has it captured the ventricle? Yes. Has it entrained the atrium? Let us move the calipers and measure them. Yes, they seem to have entrained the atrium. What is the last entrained atrial beat? This is the last entrained atrial beat. So what's the response? VAHV. The atrial activation also remains the same. So this effectively rules out an atrial tachycardia, but not necessarily an AV-RT or an AV-NRT, for which we need to measure the post-pacing intervals. The same trace, let's measure the post-pacing interval. Very long post-pacing interval. In spite of you pacing from the right side of the heart and you having a concentric atrial activation sequence. Even a visual eyeball rolling would favor an AV-NRT, but let us measure the intervals. Post-pacing interval here in this case is 436 milliseconds. Difference in PPI and TCL 146. See the return cycle or the resumption of the tachycardia, a very long AH, expected because of the decrement in the AV node. So let us correct for this AH differences. Even after correcting for the AH differences, the corrected PPI minus TCL is still more than 110 milliseconds, thus favoring an AV-NRT circuit in this patient. This is yet another trace. A ventricular overdrive pacing of 360 milliseconds. This is a different patient. What you observe here after the cessation of pacing is a VAAV response. Wow, looks like an atrial tachycardia. But however, be very careful when you note such shortly coupled V and A. Hence, you have to answer the very important question, what is the last entrained atrial beat? And in this case, this is the last entry in atrial beat. Hence, the VA linking is not the way that we thought. It is in fact such long. So the true response is VAHV response. With such long post-pacing intervals again, this was a case of slow to slow AVNRT. There could be occasions when the ventricular overdrive pacing can terminate a tachycardia. Take this trace for example. Complexes 1, 2, 3, and 4 are all fused complexes, intermediary morphology of QRS. What happens during fusion is what is very important. Did anything happen to the atrium? Yes, the atrium seems to have pulled in at the time of fusion. Now this can happen only if there is a pathway leaking the ventricular impulse back to the atrium. And hence this got to be an AVRT circuit. Response to sensed PVCs, this maneuver again is very important, and I always prefer to perform the sensed PVCs maneuver even before doing the ventricular overdrive pacing. Especially the His refractory PVCs are very important because you are starting with a foundation that a His refractory PVC cannot affect the AVNRT circuit. When you perform sensed PVCs, it's very important to understand and measure the correct intervals. And that is why this particular demonstration. The first question you need to ask, is it a His refractory PVC? In this case, measure the His to His intervals and see, this PVC looks a little premature, may not be His refractory. Has it an effect on the atrial timing? This is how you measure the atrial timing. There's no effect on the atrial timing. Did it change the atrial activation? Again, the answer is no in this particular trace. Did it reset the tachycardia? The way you measure the reset is again very important. You measure 2 intervals prior and 2 intervals encompassing the ventricular stimuli. And in this case, it did not affect the tachycardia. So in this particular trace, you do not derive much conclusions. But in the next patient here, you have a His refractory PVC exactly falling at the time of the His. Did it do anything to the atrial? It had advanced the atrial signal by a significant timing. Did it change the atrial activation? That is the third question. No. Did it reset the tachycardia as the fourth question? Yes, it has reset the tachycardia. So a sensed PVC able to reset the tachycardia talks in favor of an orthodromic reentry tachycardia, and you're pacing probably from the same side of the chamber. We could derive more conclusions as well in this particular trace by measuring the post-pacing intervals. The responses here is a VAHV response. Post-pacing interval is again very short. And the STIM2A to V2A differences are also very small, all favoring an orthodromic reentrant tachycardia using a right accessory pathway in this particular patient. Sensed PVCs can also advance the atrial activation timing and terminate the tachycardia. Or it could block the accessory pathway retrograde and terminate the tachycardia. Either way, a His refractory PVC terminating a tachycardia talks in favor of an orthodromic reentrant tachycardia. Thereby, my dear friends and colleagues, I would like to conclude by reiterating that important clues can be derived from studying the VA relationships, timing, the mode of termination. Study the principles behind these responses that you see with ventricular overdrive pacing and the post-pacing intervals. Sensed PVCs maneuvers are very helpful, and you can always try them before even the ventricular overdrive pacing. Special thanks to Dr. Yash, Dr. Ulhas, and Dr. Rajiv. They are instrumental not only in mentoring and teaching me, but also they allowed me to share much of their traces for this particular presentation. I'll be happy if any of you can share some of your traces. We can hold Zoom discussions. Thanks a lot for your patient listening. I leave this stage with a few important resources for you all to read. Thank you again.